I'd like to share with you the results for what we've been doing for the last couple of years with the use of a drug-eluting stent in the SFA and the popliteal. And these are the interim results of the DESAFINADO study. These are my disclosures. So POBA really is not the gold standard in treating a very calcified lesion, and it's very clear a patient like that with severe calcification, recoil, and dissection, this patient needs a mechanical scaffold and a leave. Nothing behind strategy is probably not appropriate for this patient. Stents work, but some questions remain. Stents are prone to in-stent restenosis, even in some modern woven stents. You do get in-stent restenosis if you wait long enough. And stents are also associated with poor expansion, and poor expansion has been reported to affect patency. In this IVA study done by our Japanese colleagues, if the stent wasn't expanded more than 5 millimeters diameter in terms of luminal area, this is associated with a higher risk of stent thrombosis. We also know that drug-coated balloons, and many of the speakers before have shown that drug-coated balloons have got good primary patency rates, but in a real-world scenario, the provisional stenting rate is actually quite high, running around 40 to 50%. So one would wonder if the results of a drug-coated balloon were due to the stent or due to the drug effect itself. And how about drug-coated balloons with combination of intentional stent? This was investigated recently with a randomized control trial. It seemed to suggest that that the intentional stenting with drug-coated balloons did not give a superior results to drug-coated balloons itself. So are drug-eluting stents the answer? In the first generation of drug-eluting stents with the Silver PTX, within the context of a real-world long TAS-C and TAS-D lesions, the conclusion of these authors seem to suggest that this first generation stent did not seem to provide the benefits in terms of patency as compared to a standard bare metal stent. Newer generation drug-eluting stents were available over the last several years. So this is the Illuvia stent we've had experience with. So this is a paclitaxel dose stent with an elution profile of about 1 year and with a biostable polymer that is used also in the coronary Promus stent platform, ranges from diameter 6 to 7 with lengths from 40 to 120. This stent is based on the Innova platform with both hybrid closed and open cell design, which allows flexibility but not at the expense of radial force. In the early studies with the MAJESTIC trial, in a controlled environment, in a short 7 centimeter lesion, this is associated with superior 12 months primary patency, extending to 24-month primary patency results. In the Imperial trial, which was a head-to-head study between an Illuvia stent and a first-generation Silver PTX stent, this seemed to suggest that for a short lesion, there was a superior primary patency of a newer generation drug-eluting stent. Within the context of a real-world scenario, we only have evidence from several centers, a Munster registry, which had a primary patency of 87% with a lesion length of about 200 centimeters, as well as the Imperial long lesion trial, which had a similar length of lesion that had fairly decent results. We sought to investigate the use of this particular drug-eluting stent in the Asian population with diabetic population. So this is a predominant diabetic population with SFA and popliteal artery stenting into the P2 and P3 segments with the Illuvia drug-eluting stent at 6 millimeters. Predominant total lesion coverage with drug, which means that if a drug-eluting stent was not used to totally cover the lesion, this was topped up with a drug-coated balloon. And this stent, prior to implanting this stent, aggressive vessel preparation was done with high-pressure non-compliant balloons prior as well as post-implantation of the stent. So I'd like to share with you some of our early results. This was a group of 69 patients that were treated. We had a 78% diabetic population with 17% renal failure. 80% of these patients had Rutherford 5, and close to 50% of these patients had stenting into the popliteal artery into both P2 and P3 area. Lesion length, median lesion length was about 200, ranging from 20 to 450, about 50% of occlusions, with about 50% of these patients with under TAS-C and TAS-D lesion. In our early results, our primary patency rates at 6 months with duplex ultrasound with a PSVR of 2.4, and this came in at 91%, and this translated to a very reasonable freedom from TLR of about 95% at 6 months. Amputation-free survival was high as well, 88% at 6 months, in a predominant CLI population, diabetic with renal failure. So in our study, compared to a real-world Munster registry, we had more diabetics at 78%, slightly more patients with dialysis-dependent renal failure, 84% critical limb ischemia, and very few claudicants, similar lesion lengths of about 200 millimeter, albeit, but we did have a smaller number of occlusions, and we were able to show that our patency as well as amputation-free survival results at 6 months were fairly similar. Of interesting note was that despite high-pressure non-compliant vessel preparation, we saw no evidence of aneurysmal change on duplex ultrasound by our sonographers. Just some case examples to top it off. This patient had a full-length CTO with a wound at the back of the tendon Achilles. This is a very nasty location to have a wound with only a peroneal runoff as a stenosis in the tibial peroneal trunk. This patient was prepped with a 6 and 7 millimeter Mustang balloon at high pressures. You can see after that, the whole vessel shut down, and this was treated with a stent. Stent implantation was done with the aid of an ultrasound to ensure no coverage of the profunda femoral artery. And subsequently, the bottom end of the stent was topped up with a Drainer drug-coated balloon that was aggressively sized. This is the final results. A bioabsorbable drug-eluting stent was actually implanted in the tibial peroneal trunk as well, in this case. Just on follow-up, the 1-year angiographic follow-up revealed that there was actually very reasonable, or the absence of any in-stent restenosis, some restenosis in the patient area of drug coating. At 2 years, we had a similar angiographic result with minimum or hardly any in-stent restenosis, and some small amount of restenosis that was below the stent in the area that had drug-coated balloon, and no restenosis on the area where the bioabsorbable stent had been placed. At 2.5 years, she remains symptom-free and freedom from restenosis on duplex ultrasound. Another patient with claudication had a similar result, a lesion length of 220 millimeters, a stenting length of 270, and this patient is diabetic, claudication, and remains symptom-free and restenosis-free at 2 years. So in summary, a new generation drug-eluting stent with prolonged drug elution provides a durable solution in a complex, long SFA and popliteal lesions, especially in a population that is diabetic with critical limb ischemia. For us, it represents a possible FEMPOP-like bypass result and may be a preferred choice for an inflow revascularization in a patient with multi-level multivessel disease compared to a drug-coated balloon, avoiding the potential problem of a slow flow with drug embolism. Thank you very much.
Thank you.